Corporation Foundation.
Good afternoon and welcome to the City Club of Cleveland. I'm Hugh McKay, past president of the board of the City Club. Healthcare reform has been a focus of national debate and controversy since the 19th century. A national opinion research poll in 1968 showed that nearly 90% of Americans believed that healthcare was a right of all American citizens. Richard Nixon called for comprehensive national healthcare, as did the Clinton administration. Finally, in 2010, the Patient Protection and Affordable Care Act was signed into law. So-called Obamacare has become one of the most controversial laws of our time. Following a constitutional challenge, the Supreme Court upheld the act. President Obama praised the decision, while the ruling quickly became a rallying cry for the Republican Party and the Romney campaign. Suffice to say, healthcare reform remains as hotly debated as ever, especially in this election year. Today at the City Club, we have an outstanding panel to discuss this complex and important issue. Our moderator is Plain Dealer reporter Diane Suchetka, who covers consumer health and healthcare issues, and who's done a great deal of excellent in-depth reporting on healthcare and the Healthcare Reform Act. Diane will introduce our panel. Diane?
Thank you. So this massive, complicated, politically divisive law, I think has befuddled a lot of people in our society. So much so that there was a poll that was conducted in the 2 days after the Supreme Court ruled to uphold most of the law. And 35% of Americans, when asked if the court had ruled, either said, "I don't know," or "No, it hasn't." Another 6% were smarter and said, "Yes, of course the court has ruled," but they didn't know how. That's why we're here today. We have on this panel collectively decades of experience in healthcare and public policy, and they're going to bring us up to speed on both the law and the Supreme Court ruling. To my left is John Begala. He's Executive Director of the Center for Community Solutions, which analyzes and explains key health and other issues and proposes nonpartisan solutions to make life better for all of Ohioans. He's a senior fellow at the Urban Center at Cleveland State University's Maxine Goodman Levin College of Urban Affairs, and on the faculty at Baldwin Wallace University, where he teaches a class in leadership and biomedical ethics. John, in the past, has served as Senior Vice President of the Metro Health System in Cleveland and 3 terms as a member of the Ohio House of Representatives. Next to John is Bill Ryan, President and CEO of the Center for Health Affairs, which lobbies for hospitals throughout Northeast Ohio, and he's also heads its affiliate, Champs Healthcare, which provides business management services to area hospitals and healthcare organizations. He previously served as Vice President for State Policy and Advocacy for the Ohio Hospital Association, as Director of the Ohio Department of Health, and Deputy Director and Chief Operating Officer of the Ohio Office of Medicaid. And next to Bill, Danny Williams, the Executive Director of the Free Medical Clinic of Greater Cleveland. The clinic was founded 42 years ago and is Ohio's newest federally qualified health center, which means it can now serve Medicare and Medicaid patients in addition to the uninsured. Danny previously served as Senior Vice President and General Counsel at the Greater Cleveland Partnership, as General Counsel and Cuyahoga Metro Executive for the Ohio Division of the American Cancer Society, and as the Cuyahoga County Administrator and the City of Cleveland's Law Director. I would like to open today by asking each of our panel members to tell us, because this is such a complicated law, 1 or 2 things they'd really like for everyone to know about healthcare reform. Let me start with you, John.
Okay. Well, there's so much to say about it, and we're just going to scrape the surface here today. Number 1, the Supreme Court ruling and its implications are not completely understood, and it's going to be months, many months, before we're able to fully digest how this plays out. Secondly, Medical science is extraordinarily complex. We are all the beneficiaries of it, and that's a good thing. Healthcare finance is extremely complex, and that is not a good thing. We're trying to keep up on the finance side with the complexity of the medicine, and it's just not working for us. So simplification is something that we could all benefit from. Third, prevention needs to find its way up the priority list in American culture. This is not simply a matter of public policy. This is something that we as a society need to embrace, or in our children's lifetimes, Medicaid will represent 100% of the American economy. And finally, healthcare costs have to be at the top of the agenda. By all means, healthcare is a right. Danny Williams has a button that says so. On the other hand, it is currently probably about a fifth of the American economy. That's almost double that of any other developed economy in the United States, and certainly double the average of other OECD countries. And we can do better than that.
I would echo a lot of what John said, but one of the things I would also suggest to folks is this has been positioned from a political perspective as an incredibly radical idea, as an idea that is in its very nature socialism. The fact of the matter is this bill was created almost whole cloth from a discussion piece that was put together by the Heritage Foundation. The Heritage Foundation is one of the most conservative think tanks in Washington, D.C. The proposal itself preserved the market approach to healthcare that we have today. It is not government-run healthcare. It certainly puts more financing controls into the government's hands, but it is not sort of a social healthcare system as you would see in Canada or in parts of Europe. I think so much of what has been said about this bill has been said to score political points, one side or the other. Very little, when you actually go through the elements of the legislation, when you actually bother to read the law and explain it to people, people universally have favorable opinions of the elements of the law. They have favorable opinions about the caps on insurance premiums. They have favorable opinions about the ability to keep their children on their insurance. They have favorable opinions about limitations on exclusions for pre-existing conditions. I think if you can say one thing, the Obama administration has done a horrible job of presenting this legislation to the people in the United States in a way that they can understand, and they've lost the conversation because the other side has spun it in a different direction.
Danny?
You know, when I think about this very complicated bill, there are two aspects that really, I think from the standpoint of sort of grassroots level safety net provider that come through. One is the expansion of Medicaid. And now I know there's some debate about whether or not that's going to happen in Ohio, but just the sheer fact that the bill is trying to get more people access to care by having some kind of a card will get them in some place, theoretically, is to me incredibly important. I think that those who are opposing that aspect of the bill are maybe looking at some unintended consequences. I mean, even with Medicaid expansion, there was just recently a study that suggested that, I forget who put it out, but suggested that fully a third of doctors would still turn away Medicaid patients. There's still no guarantee of care just because you have the card. But if you don't have the card, you almost have no chance other than in places like the free clinic or other smaller networks of safety nets. So that's, to me, an incredibly important part of it, and I would really urge the governor to think long and hard about not going to the expansion, because it has implications, for example, for the hospitals. I was hearing recently about how it's thrown the hospital community into this unfortunate debate about, well, is it better that we may not expand Medicaid because it may mean that we'll retain our disproportionate share payments? Which calculation is better for the financial health, which is, I think, an analysis they have to do. but it unfortunately leaves out the most important aspect of that, and that is more people would have access to care.
I think anybody who reads the bill actually knows that there is no preservation of disproportionate share payments, regardless of what the state does.
Well,
but
it's a distraction, though. I mean,
Yeah.
you know, yeah. And the second thing I just want to say, and then John, I'll get back to you, but the second thing is more philosophical, because what the bill does is it changes the conversation. So I think now, with the passage of this legislation, you're having more businesses thinking about the impact that having a healthier workforce can have on their bottom line. There was just SHRM, the Society of Human Resource Management, just put out a survey, or results of a survey, where they found that 21% of employers surveyed by the organization are offering a discount off their employees' share of insurance premiums to workers who just will complete a health risk assessment, compared to 11% just 4 years ago. And they go on to talk about how some of these other things that getting people to pay attention to quitting smoking and other prevention-related activities are resulting in them being able to save money that they can pass along to their workers, and the workers are actually even more productive, and that, which again redounds to their bottom line. So, I just think that that change in the conversation about whether or not this is an important issue is one of the other catalysts from this legislation.
The second question I want to ask, just so everybody's sort of on a level playing field and understanding the basics here, are what you would like people to know about the Supreme Court decision, and particularly, of course, as it affects Medicaid and what might happen in Ohio. So, Bill, you want to start there?
Sure. The Supreme Court decision is, as John said, very, very complicated and nuanced. There are a lot of sort of moving parts in it, and it really does create some dilemma. One of the provisions in the bill required states to expand their Medicaid programs to take in significantly more, particularly single working people at lower incomes. And the court ruled that that was too coercive an approach and gave states the ability to opt in or opt out. Once that decision was made, a significant number of states, particularly states with Republican governors, declared that they would not choose to opt into the Medicaid expansion. What I will say in terms of Ohio is Governor Kasich was a little more thoughtful than some of his Republican peers around the country. He said he needed to evaluate it. He understood that he had an option and that it could be an important tool relative to expanding health care coverage, but he had financial concerns about its implications for the state's budget. As a former Medicaid director, I completely understand that, but my argument back would be that there are hundreds of millions of dollars at risk for the state of Ohio should they choose not to do that.
Before I go on to Danny, I think I want to ask each of you to also address how political this decision by these governors not to expand Medicaid is, and do you think we'll see great difference? Are they waiting for the election? Will we see a big difference after the November election? Do you mind addressing that?
No, I don't mind. It certainly the initial reactions are extremely political. They're very partisan. But to be fair, Medicaid is a very expensive program within a state budget, and it is not a particularly popular program in state legislatures where they're struggling to fund a variety of different activities. They're struggling to find dollars for primary and secondary education. They're struggling to find dollars for higher ed. They're struggling to find dollars for other services that the state is required to provide in an environment where their ability to raise revenue has dramatically declined. And the current Medicaid program has the potential to eat up virtually every new dollar that comes through the door. It's a real struggle for governors to figure out how to bring some balance into that. It is particularly difficult for governors because they don't have very many tools to manage the program. The requirements in terms of what services are delivered are set at the federal government. The requirements with regard to which providers are eligible is set by the federal government. Really, the only tool that states have is to restrict eligibility or cut payments to providers. And that's a difficult exercise, as we've seen over the last 25 or 30 years as the state legislature has wrestled with trying to reduce payments to nursing home providers in the state of Ohio.
Do you mind if I jump into this
No,
real
go
quick?
ahead.
I'm going to ask everybody to follow me down the rabbit hole a little bit because we're going to go get into the complexity here and this is how the Supreme Court decision doesn't exactly wreak havoc, but it sure creates some interesting wrinkles along the lines of what Bill was just saying. There are two things that expand coverage in the Affordable Care Act. One is the mandate. With the mandate comes a set of subsidies that the federal government will make directly from the Treasury as part of your tax return. It's a refundable tax credit that will go up to $11,000, give or take, for a family, depending on your income level. So you've got a refundable tax credit that will cover you between 100% of poverty and 400% of poverty. And then there's the Medicaid expansion, and the notion behind the Medicaid expansion is that would take you to 138% of poverty, so that those subsidies, those tax subsidies over here, wouldn't be reaching people the way the bill was passed, between 100 and 138%. That was put down on the states, along with all the coverage gaps that the states have for those below 100% of poverty. And we have a couple big ones here in Ohio. So I hope you're with me so far, because here's the curveball. If the state of Ohio, with the Supreme Court saying, look, states, you don't have to do this. Now the state of Ohio is in a position to say, wait a minute now, the exchanges we don't have to do. We'll let the federal exchange operate in Ohio. And let's punt the coverage of everybody from 100%, all those subsidies for people 100 to 138% of poverty, to the federal treasury. Now we're going to get 100% Medicaid money for the first few years for that group of people, but then it starts to go down 1% a year. Well, you can punt all of that to the federal government. So when you're looking at a Medicaid budget in the state of Ohio that in 1980 represented 7% of state spending, leaving the federal funds out of it, and today represents 23% or just about a quarter of state spending, now you've got to start to look, how do these things balance out? If we can punt those costs down to the federal government, maybe we ought to do that. But here's the twist back. The Obama administration has said you can't do a partial expansion and cover all those gaps under 100% of poverty. You got to take it all, or you don't get it all. And if you don't take it all, you lose the 100% money for covering those things down below. So however this comes out, after the election, whoever wins, whatever happens in Congress, they're going to have to revisit this, because you've got this playing out differently in all 50 states. And you need a scorecard on these things if you do it every day. For the general public and average people trying to keep up with this stuff, it's hopeless. And this gets back to my point earlier. This all needs and can be simplified. And we need to insist that people in both parties do something about simplification.
It's even more complicated than John just said. It's even more complicated because the tax credits don't kick in unless you buy credible insurance. Right. And you have to assume that people who are working at incomes of about $25,000 a year for a family of three do not have the disposable income to pay those premiums. So they will continue to receive their health care in emergency rooms, in places like Danny's facility. And the kicker is a significant funding stream that exists in Ohio today to help offset some of those costs. Hospital care assurance, we referred to it before as disproportionate share payment, sends about $400 million to healthcare facilities, primarily hospitals, every year to offset those costs. That money, regardless of what the state does, will disappear. And it will put hospitals in a significant issue of stress in terms of still having to see patients at the emergency room level, still having to provide emergency care and hospital care, and having no resources to do it. And it really will create a crunch. It will also create the incentive for a very strange coalition to come together to support Medicaid expansion. Small business people, community advocates, hospital advocates will be lobbying very aggressively for, I believe, for an expansion of Medicaid under the Affordable Care Act.
Well, I feel some pressure to add one more layer of complication to this because, and that is that if the state does decide to punt and allow, for example, the federal government to set up the exchange, there's this one argument that's being raised by the Cato Institute, and I think there's a professor at Case that's on board with this as well, that basically says that credit that you referred to earlier is not available for a federally constructed exchange. It's only available based on some arcane language in the legislation if it's a state-constructed exchange. So, that's another thing that could undercut the ability of individuals to do that. Now, the Congressional Budget Office disagrees with that. Other, academics disagree with it. But there is that argument that if we do allow the feds to set up our exchange, that people who need that subsidy to be able to, afford, some kind of coverage wouldn't be eligible for it.
Well, the next question I want to ask, and maybe you feel like you've each touched on this, but I want to ask if you have anything more to say on this, is should Ohio go ahead and expand Medicaid? But before you answer, just to be clear, right now, if Ohio were to expand Medicaid, it would cover basically single adults. The additional people it would cover would be single adults without children. And right now, they qualify for Medicaid if they earn 90% or less of the federal poverty level. And this would take that up to 138%. You guys are going to correct me if I've got this wrong, right? Yeah, that's right. So you see that it's going to be a pretty big pool of people, and that's going to be most of the additional folks who would be covered by Medicaid, not all. So do you want to add, and does anybody want to add anything to whether or not Ohio should go ahead and do this, and why or why not?
Absolutely, John? Ohio should go ahead and do this. And one of the best arguments for doing so isn't just that up to 138% part. It's that there are a large number of very needy people who do not have families, do not receive disability benefits, who are under the poverty level in Ohio, many of them with mental illness. And that population is expensive on all fronts of the healthcare system. We pick up 100% federal money in the state for covering that population. That's a good deal. On the other hand, and that is probably, by the way, the most needy population that there is out there. One of the benefits of doing that would be that if we get coverage, third-party coverage, especially for mental health benefits for all of those people, there's an opportunity to do something to vastly improve the quality and scope of mental health services in Ohio, which are so grossly underfunded at the local level as to be criminal. I mean, it's a terrible situation. So that's one. The downside to this, though, is cost, and there's got to be red flags on all of this. If we don't do something to significantly rein in the rate of growth in healthcare costs, including pulling some of the money somehow out of the system that's being flushed into it with all of this, the whole thing is going to go belly up. It's on a collision course with reality. It is not sustainable given the money the federal government takes in now, and given federal taxes, and given Ohio's tax code and what it produces. The revenue's just not there. And we're not doing ourselves any favors by pretending that somehow we can punt this down the road. With federal debt and deficits being what they are, the punting days have to come to an end too.
Bill, I really want you to address this, but I want to ask Danny about it first, just because you will be now caring for Medicaid patients.
Sure. Well, I want to address this in two ways. The first way that we don't often hear people talk about is that we ought to do this because we ought to care about our neighbors. All right? I mean, it's an old-fashioned concept, but we ought to care about the people who don't have access to care. And sometimes we take for granted because we do have access, it's just not my problem. And so, I'm hoping to hear more from the faith community and others for whom this is their primary business, to make the case that it's an ethical, moral obligation that we ought to make some mechanism for making people, giving people access to care. I mean, John made reference to the button I wear every time I've got a lapel to wear it on that says healthcare is a right, not a privilege. That's kind of the mantra of the Free Clinic and of many other safety net providers around the country. And so that's one primary reason I think that it ought to happen. But the other reason is that for it to not happen, the cost of caring for these folks is not going to go away. Just because you stick your head in the sand doesn't mean the rest of the world's not still there. And so they're still going. They're waiting till they're sicker. They're showing up in emergency rooms. For those of us who have health insurance, fortunate enough to have health insurance, the cost is baked into that. The Families USA and then I think the Center for American Progress have both looked at the estimated cost of this. So right now, the estimated cost for a family health plan somewhere in the neighborhood of $14,000 a year. Now, if you're working, you still maybe at least half of employers or a little bit more are, helping to subsidize that. But baked into that cost, the estimate is about $1,100 of that $14,000 is estimated to cover the cost of the uninsured. So it's still there, even for those of us who have health insurance. One estimate I had nationally of the cost of uninsured nationally is about $43 billion. So the question is, do we want to manage this better than we're managing it now? Because it's going to be there, and these folks are going to get care. It's just they're going to wait until they're sick enough they have no choice but to show up in the least efficient way to get it, and that's in an emergency room.
So, Bill, I want you to talk about this, but I hope in your answer you'll address this question. Are we just going to be paying for the health care of these folks out of a different pocket? Now it's going to be coming out of our Medicaid tax dollars instead of our higher insurance premiums or our higher hospital bills because we're covering those folks who are showing up uninsured in the emergency rooms.
I think people who suggest that this legislation isn't as encompassing as it should have been think exactly that way. They think it's just moving sort of deck chairs around the Titanic. And to be honest, if we do not build a significant component of primary care delivery in our community, we do not focus on, as John suggested earlier, prevention, it could very well end up that way. I mean, when I ran the state's Medicaid program, we used to sort of have the gallows humor of referring to Medicaid cards as hunting licenses. You get your card and you have to go out and hunt for a provider who will actually deliver services to you. If this expansion results in people getting Medicaid coverage and still going to emergency rooms in places like the Free Clinic and the other federally qualified health centers, you do just end up with sort of a churning in the environment. The theory is there's certainly pent-up demand, and it will flow into the system very quickly. But the theory is that once folks who are currently uninsured deal with that pent-up demand for health care services, their health status should improve, and as a result, everyone's costs should go down. Now, the fact of the matter is the cost of health care and health insurance in particular will continue to rise. It will continue to rise because of technology. It will continue to rise because of treatments being developed to deal with disease and injury that we never had before. But if we can slow that growth, and if you can improve the overall quality of health for a huge population, you can actually get this to a place that's manageable. But so many people are disappointed in the bill because it didn't address the real, and particularly the liberals are unhappy because it didn't address the key cost drivers in health care.
John, we're going to move on to questions from the audience, right?
Today at the City Club of Cleveland, we're listening to a forum on the Health Care Reform Act We will return to our panel in a moment for our traditional City Club question and answer period. We encourage you to go ahead and formulate your questions. Please remember to keep them brief. We welcome all of you here and those listening to 90.3 WCPN Idea Stream, WCLV, WTAM, or one of the many radio stations across the country. Our television broadcast partner is WVIZ PBS Idea Stream. Television broadcasts of the City Club are made possible by Cleveland State University and PNC. Our live webcast is supported by the University of Akron. We'd like to welcome guests today. Tables hosted by Baker Hostetler and Western Reserve Area Agency on Aging. Thank you for your support. Today's forum is the annual forum of the Power of Ideas, made possible by the 1,400 attendees of the City Club's 75th anniversary celebration, Power of Ideas. Now we'd like to return to our panel for our traditional City Club question and answer period. We welcome questions from all of you. Holding the microphone today is City Club Development and Marketing Assistant Mike Cromaldi and Program Director Carrie Miller. First question, please.
Yes, gentlemen, getting back to the area of politics perhaps, I do have to praise Governor Romney for having gotten health care passed in Massachusetts. I do believe that the Affordable Care Act was fashioned a good bit on that particular law. And I also believe that the only way they could probably get it through Congress was through a mandate. Certainly at the moment I can't understand why he doesn't like the Affordable Care Act. I'm sure he can get something. But the question is, do you think that it would be good to have the Affordable Care Act without the mandate, as the liberals wanted originally?
Well, the liberals actually wanted something even more significant than a mandate. What they wanted was Medicare for all. They wanted everyone to participate in the Medicare program. And there are significant financial reasons for doing that. It would be cheaper than going through the commercial marketplace. The government would have significant price leverage. Your assertion that Romney Care or the Massachusetts model of health care is essentially identical to the Affordable Care Act is absolutely correct. They came from the same place. They came from a white paper issued by the Heritage Foundation. And the mandate was placed into the bill at the behest of the commercial insurance market. The commercial insurance market required, for their acquiescence to the bill, an individual mandate. They said there's no way we can make this work if there are free riders.
Yeah, and we call it Obamacare. So there is one thing buried in this that I think might still be achieved, and I'm probably going to part ways with the people to my left, your right, here on this, and that is that I personally, this is not the position of the organization I work for at all, but I personally think the mandate was a very bad idea. And I say that from the perspective of simply this. I don't want 20 years from now the NRA saying that I've got to buy a gun and join the militia. I mean, that precedent as far as the Commerce Clause, I think it was a terrible mistake. It's politically wrong. It raises all sorts of red flags that obscure what really needs to happen. I think that the idea of how we're covering many of the uninsured with the tax subsidies, earned income tax credit sort of model is exactly right. That is, provide money out of the federal treasury, let people go to the marketplace, and Danny's right. At the front end, there are going to be an awful lot of average people that are going to go out there and be befuddled, and for anybody who's had to buy health care insurance benefits for your employees, you know how difficult it can be. It's complex. On the other hand, most people can figure out most of what's in those products. And let people go to the markets. I think that fits the mixed market model of American capitalism and the welfare state as we know it in this country. It's simple to do. And getting the money to people up front is something that can be worked out. The complexity of doing all this stuff with Medicaid and so on and so forth has been great for the healthcare consulting business, and it will continue to be great for the healthcare consulting business. Yeah, great. Yeah.
Well, you know, and I want to thank John for at least finally giving us something we can disagree about, because on this issue of the mandate, I do think it was part of the deal. It was part of what sold the deal, and sometimes you have to have things like that that are not inherently inappropriate anyway. I mean, it's a little bit paternalistic, but I don't think the analogy to the NRA is appropriate, because you can avoid, you don't need to have that. Inevitably, everyone in this room is going to have some involvement in the healthcare system, whether you like it or not.
Well, Dan, I don't completely disagree with you, but here's the thought, though, on that.
Well, you know what my point was, yeah, but let me hear your thought first.
The earned income tax credit
Right.
is now taken by a third of American families, and a very significant number of people making $50,000 a year or below. So people caught on to that. They figured out how to work it and how to get the checks. Same principle.
Why would you disaggregate purchasing power, though? I mean, the whole point, you talked about it before. The biggest concern is trying to control the growth of spending on healthcare. And you give people checks or vouchers or whatever, and they go out and they interact with the market as individuals.
If everybody's in, you community rate it, and you're there.
Well, that's a whole different set of arguments in
Right.
terms of community rating and in terms of how do you build a pool. But that's, when you talk about sort of eliminating the requirement that individuals carry health insurance, it becomes incredibly complex to simply say, we're going to give you money, you go out and do the right thing with it.
Yeah.
Well, but John, no, I want to get back to the point that, number one, the deal probably wouldn't have gotten made if that component wasn't there. So, I mean, I think that's a fair consideration. And the other thing is, when you look at the actual cost, I mean, estimates have been that fewer than 2% of folks would end up getting hit with a penalty for not complying with it. They either would be covered in some other way, you get a subsidy to be able to get it. I think CBO suggested it was 1.2%. So you got a significant benefit from having the mandate in there, and a fairly small cost, to those who are going to be affected by it if they, were not to get insurance. So when I look at that cost-benefit analysis, it seems to me it's a worthwhile thing to have gotten this legislation through.
One of the unintended consequences that some of the opponents of the law have proposed is that it will discourage small businesses from expanding so that they stay below that threshold of having to offer coverage. Is this a valid criticism, or is this something that doesn't stand up to analysis?
Well, I'd like to see the evidence of that, and we'll know soon enough. But I think it's dubious. Businesses expand and contract for reasons other than buying health insurance for their employees, for God's sake.
Benefits are a cost of doing business, and what drives, John's right, what drives expansion of business is customers. Yeah. Customers with money to spend. And to the extent that those individuals are able to afford health insurance or have subsidized health insurance, individuals actually have more money to spend. I hear this all the time. I just saw an article a couple of weeks ago that the president of Papa John's is going to raise the price of pizza because of Obamacare. It hasn't gone into effect yet. How is he raising the price of pizza because of Obamacare? He's raising the price of pizza because the price of cheese has gone up.
Probably be the best thing to happen to heart health in the United States.
Not from my perspective.
The other thing I'd say about that is there has been some research that suggests that this generation of workers are looking at benefits as a key component of whether or not they want to work at a particular place. And so I would argue that being able to offer competitive health benefits it gives you a competitive advantage as an employer. So I'd really say to small businesses, you better think twice if you want to start stripping down some of the things that your current workforce is looking for in terms of a quality of life benefit.
I understand that that we're the only country in the world that's willing to let babies die without medical care because their parents lost insurance, lost their jobs. So what does that say about American culture?
Actually, I think the country has done an incredible job of ensuring that children are covered by some form of insurance. When you look at children, and particularly young children, and the percentage of those children who are without insurance, it is in the low single digits.
It's below 5%.
So we have actually responded somewhat progressively on that front. But your point is well taken, because how do you value an adult's life differently than a child's life? How do you value anyone's life differently than the individual sitting next to you? And that really is, and Danny talked about it before, that's the moral sort of issue that's here. Is health care a commodity? Is it a market good, or is it something that we're all entitled to? Is it a right?
And I would say that's not a fair criticism of American health care, because even before the passage of the state child health insurance program, neonatal intensive care units across the United States and large teaching hospitals opened their doors to neonates that could not have survived in probably all but a few other countries in the world. At basically, the rest of us absorbing that cost when they're uninsured. But that points to another part of the Affordable Care Act that's real important. That's that emphasis on preventive care. Think about how much you save by providing health care during to the mom before the kids are born, and seeing that there's adequate health care during those first few years of life. It's extremely important. And we're willing to invest bazillions of dollars on the technology side, and not willing to put, until the last 10, 12 years, the money up in the front end.
We ration care in this country in exactly the opposite way that makes sense from an economic perspective.
Right.
We ration the cheapest care, the interventional primary care, and we give away the most expensive procedures that exist. If you show up at the emergency room in cardiac failure, you're going to get the cardiac procedure that's necessary to save your life. But we won't subsidize the visit to the primary care doctor that would keep you from developing heart disease.
Yeah.
Gentlemen, despite all the uncertainties about the law, it is quite clear that there will be millions of people having health insurance for the first time. And of that number, there'll be tens of thousands in the greater Cleveland area who have health insurance who never had it before. To what extent do you feel that our Cleveland hospitals, as they're now constituted, are going to be able to handle the additional number of cases that they undoubtedly will have, or will there have to be a new program to expand those hospitals?
I think hospital capacity for hospital care is currently sufficient. I think where we'll have struggles is, do we have a sufficient number of physicians and specialists, both primary and specialty physicians, in the communities where these people reside? It's not good enough to have a bunch of specialists out in Westlake or out in Beechwood if this new population lives in Mount Pleasant or lives in West Park. We're going to have to figure out how to deliver primary and initial medical care to communities that are not right now very well served.
Danny, are you going to be able to staff up?
Well, I mean, one of the advantages of becoming a community health center is that there are additional dollars that go along with that allow us to hire additional primary care staff. Now, finding them in an environment where there's a national shortage of those folks is difficult. But again, you also become eligible for programs that allow loan repayment for certain kinds of professionals. So, we think we'll be able to compete for that. But I also see on the hospitals, I think, are trying to do a better job of connecting to organizations like us, the other community health centers in town, so that they can deliver that care in a more cost-effective way, and in settings that people are more comfortable going into. I mean, some of our hospitals are, the great care is housed in facilities that are somewhat imposing. for some folks. And it's easier to get folks to come to places where they just feel it's a little bit more accessible. Then we got organizations like I'm on the board of CHAP, Cuyahoga Health Access Partnership, where the goal is to try to make sure that there's no wrong door, if you will, so that people who need access to primary care or specialty care can, get enrolled whatever door they go into, can get enrolled in a program like that, and it can help. It can be like a clearinghouse to get people to the care they need and to even it out somewhat. Because what happens is the world tilts in a certain direction. If they think that if the reputation is this is where you go to get certain kind of care, the world kind of tilts in that direction, whether or not that's true. But we need a mechanism for spreading that around so that there is capacity, and where that capacity is, the people can be funneled there.
I think there's general agreement, not only by this panel, but everybody pretty much, that the status quo in healthcare has been unacceptable, and that this law isn't indeed perfect. But I'd like to hear what the panelists have to say about to what extent do you feel this law is actually a big step forward and is going to allow us to begin to move that big ship, to change the direction of the ship from being a sick care system to actually being a health care system. And I was glad to hear you speak about prevention and primary care, the consumer protections, and to what extent is this a work in progress, and are changes already making a big difference, whether they're contained within the Affordable Care Act or actually happening because of it elsewhere?
I'll start. One of the things I think that the Act will do, and I referred to this earlier, is that it will inspire other kinds of activities. And one example is there was a recent study out of UC Irvine, I think it was issued back in February of this year, where they looked at the impact of having people who were enrolled in a community-based kind of healthcare environment. And what they found was that people did increase their use of primary care services. Over a 3-year period, what they saw was that it increased, went from about 1.06 visits a year to 1.6 visits a year. So there was an increase there, but there was also a decrease in emergency room use, and it went from about 1.02 visits a year to 0.74. So what the Act is going to do is to inspire more places to be able to track that, it is changing behavior. And it is pushing people more in the direction of seeking earlier care for things that may otherwise develop into more serious chronic care that's much more expensive to deal with. And people are tending to, if they have access, they're tending to not run to the emergency room because they know they can get to a primary care provider that can help them with their problems.
When I think about the law, I really think about it from the perspective of it's not healthcare improvement. It's a dramatic law that changes the commercial insurance marketplace. So in terms of it being dramatic, it's a dramatic law in terms of changing the commercial insurance marketplace. It doesn't do much in terms of changing the way healthcare is delivered, but there were so many other things going on at the same time. You've got the medical home movement that is emerging in this country. You've got the accountable care organization approaches. We need to think differently about what sorts of clinicians will drive primary care delivery in this country. The economics of someone who has gone to medical school becoming a primary care physician are very challenging. You have to do it for something other than economics. So I think of the bill as a dramatic move forward on improving the commercial insurance program. But I do think there are still significant issues with the delivery of health care and how we do it in a more effective and efficient way.
Yeah, I think that's right. Changing the way health care is delivered is not something that can be done uniformly across the country because health care is done very differently in different regions of the country. There's a strong nonprofit and public tradition in the Northeast and industrial Midwest. In the South and the West, most health systems are for-profit. Prices relatively comparable. So what does that tell you about the economics of health care? Only that there's something there that I don't know anything about. The biggest, Bill mentioned getting people into primary care and supplier-induced demand. The biggest problem, and it's inherent in healthcare, that we have is trying to manage a system where the suppliers are the customers. Doctors and nurse practitioners order the care. Patients don't. I can't go get, I know I've got a sore throat and what I need for it, but I've got to go see a doctor to do it. Same thing for everything in the system. They've got to write it. Well, they're getting paid to write it, and there's no way around that reality. So trying to get things right in that regard means some kind of changes need to be made about the supply of who it is that's writing those things. We have a significant undersupply of primary care providers and huge numbers per 10,000 population of subspecialty docs across the country and health systems that build around those subspecialties. That we've got to change. Medicare subsidizes every nickel of graduate medical education that there is in the way of public subsidies. And it's something very few people know about, but it all goes through the inpatient side of hospitals and into the residency programs. Some of that money needs to be redirected into ambulatory settings like Danny's place, where the rotations are done there, not for 3 weeks as part of a 3 or 4 year residency, but for 3 years. 3 years as part of a 3 or 4 year residency, and get residents into those places so they're comfortable practicing there. That will change the culture of medicine. That government can do that is also not a proven proposition.
But I think, the bigger dilemma in terms of how physicians decide to practice is the conversation and the culture at the medical schools. Doctors are told in medical school what specialty, almost on the first day, what specialty you want to focus on. And if they say primary care, the faculty at the medical school essentially laughs at them and says, well, hope you can get that second job at Home Depot. Because it just, the income capacity of a specialist in comparison to the income capacity of a primary care doctor it's like a factor of 2.
At least.
You had said that Obama had done a horrible job explaining the bill. And I'd like each of you to respond. If you could pick one aspect or whatever, what would you pick to explain this better to people so that people understood it?
Well, I think that they simply haven't done a very good job of making it personal. You think about the presidents of this country who have done things significant and been able to communicate to the American people. In my lifetime, there are 2 people, maybe 3, Ronald Reagan and Bill Clinton. Never talked about policy without pointing to an individual that the policy affected. Never talked about, to some degree, President Obama is a wonk. He's a policy guy. He likes all the nuts and bolts, and he talks about the nuts and bolts. And they didn't do a very good job of talking about what the whole car was going to look like. I don't buy a car based on the fact that there are stainless steel rivets in the trunk, right? I buy a car based on what it looks like and what I'm told it's going to perform like. And they really needed to do a better job earlier. It's almost too late, but they needed to do a better job earlier of making this personal, making this a program that had real people benefiting from it. And they just didn't do a very good job, and they let the Republicans control the conversation.
I agree with that completely, in part because I think some of the opposition to the act, number one, is partisan. I mean, people view it as that is President Obama's Achilles heel. If they can undercut this, then they really basically can undercut his first term, and he's more vulnerable. So, I mean, part of that is that motivation. But the other thing that they could have done, I think, is to humanize this, to show a broader face of who it helps. Because some of the opposition is based upon not so thinly veiled assumption that the people who this helps, I don't really care about anyway. A lot of the opponents, they just don't care about that population. They have a certain assumption about who the population is. They're not folks who they have an affinity for, either because everybody they know has insurance or because they assume the people who don't have insurance don't have it because they're not worthy anyway. They're too lazy. They don't have the whatever it takes to the initiative to get covered. And that's the assumption that often is there in a not too veiled approach. And so doing something that shows that this really helps a pretty broad spectrum of people, even people you care about, I think would have been a smarter strategy.
There's a provision in the law that requires that if your insurance company spends less than 85%, I think it is, 85% of your premium dollar on delivering health care, they have to refund those extra dollars to you as the premium payer. It's easy to have hindsight, but I would have had a website up calculating how much money you're going to get back from your premium as a result of the passage of this law. Because, you can do the calculations. You can look at insurance companies and say, okay, on average, they were running at about 78% medical loss ratio. That 7% gap results in fungible dollars that go back to premium holders. I think the administration felt like they had done the work inside baseball. They had lined up all the providers, they had lined up the insurance companies, they had lined up small business and the Chamber of Commerce, and assumed that those folks would go out and carry the water for them. In much the same way they assumed the banks would carry the water for them after TARP. And what they found was everybody took what they got and went away to their own little corners and kept their mouth shut and let the administration sink or swim on its own.
Today at the City Club of Cleveland, we've been listening to a forum featuring a panel discussion on the Healthcare Reform Act. Thank you, panel. Thank you, ladies and gentlemen. This forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.
PNC is proud to support the presentation of this City Club of Cleveland Friday Forum on WVIZ PBS.
Additional support comes from Cleveland State University. Support for closed caption transcripts of City Club forums is provided by the Nordson Corporation Foundation.